going to try to get through some slides on our work currently, much of which is done in collaboration with my partner Andre Machado in all of this, that deals with stroke and Parkinson's disease and the use of deep brain stimulation for its treatment. Some disclosures there. Largely, the first part of my talk will be related to a phase 1 FDA trial. So it is off-label use of deep brain stimulation. So again, getting back to where I've managed to wind my end up, essentially, and my elevator talk of what I do, my focus is largely on targeting network-based modulation of neural activity in order to treat human disease. We are involved in therapy development, refinement, and also, where possible, translation. Much of my efforts have been largely focused on motor physiology and pathophysiology underlying those diseases as something that we need to better understand in order to treat them, and then the mechanisms and side effects of the therapeutic benefits and side effects of the treatments themselves. The populations that we deal with are along the lines of acquired brain injury, of which stroke is the principal one within that category, though we're expanding out to traumatic brain injury most recently, as well as Parkinson's disease for about 20 some odd years. We work in a wide range of models. We have rodent models, primate models of disease, as well as intra and post-op human studies, including the clinical trial that I'll be talking about. So I tried to do this a little bit as a what is called open house type of situation, just sharing what it is we're doing, what is the ongoing features of our laboratory, as I felt that would be the best way to try to promote your appreciation of what we do, maybe develop synergy, find points of common interest, since we are very local neighbors. So the first part of my talk is dedicated to stroke. I'll be talking about the Eden trial, how it came to be, the preclinical evidence that we used to support it, and the current status of the actual in-human trial. I have one slide on the ongoing preclinical work in that area, and if there's time, I'll transition to the work we do in Parkinson's disease humans and non-human primates. So stroke is obviously a major issue in this country. It is a leading cause of long-term disability. The numbers are along the lines of 800,000 cases per year, 85% of which are ischemic in nature. And 50% of those individuals will find themselves still suffering from stroke-related disability 6 months post-injury. This translates to what are estimated to be costs on the order of $37 billion, indirect and direct. What we're doing is not novel in the sense of the efforts to actually use neuromodulation to promote vicariation. That has been done and continues to be done with non-invasive approaches, including the transcranial magnetic stimulation, transcranial direct current stimulation, peripheral nerve stimulation, as well as invasive trials involving either vagal nerve stimulation or even direct cortical epidural stimulation, which, if any of you happen to remember the North Star trial, that is what's represented here on the right-hand side, where they placed paddle electrodes directly over the perilesional cortical areas in an effort to modulate the activity and promote recovery. Back in 2005, we drew this doodle for our first R21 submission. I think it was PhotoDraw, based on an idea that I think I would date back to 2004, which came from Andre, about another possible target in the brain to help modulate perilesional cortical excitability, and that is the dentate-thalamocortical pathway, which is a disynaptic net excitatory pathway that originates in the dentate, passes through, or essentially terminates in multiple subnuclei of the thalamus to modulate thalamocortical activity across widespread brain areas. We knew at that time from decades worth of research that if you did single pulse stimulation in the dentate nucleus in anything from rodents to baboons, single pulse electrical stimulation would result in an increase in the probability of a neuronal discharge in the cortex about 3 milliseconds later. So we knew that this glutamate pathway was a fast pathway and it was a relatively robust pathway. We also knew that, in contrast to how we drew this originally back in 2005, that from papers from Dumm and Strick and other imaging work, that the distribution of these pathways is far greater than what is shown here, extending medial, lateral, out to the frontal poles, and back into parietal cortex. So these pathways are not only a robust excitatory pathway to the cortex, but they also cover the areas of the brain that are typically preserved following a middle cerebral artery stroke, and the typical areas that we might want to have take over function. So our question was essentially, can we enhance post-stroke rehabilitation through continuous electrical stimulation of those endogenous ascending cerebellar cortical pathways? Our hypothesis, much like the neuromodulation approaches I already mentioned, was essentially whether or not we could increase perilesional excitability, which has been linked to increasing plasticity and promoting recovery. So essentially, our drawings got better, because we didn't do them, showing the dentate here going up through the thalamus to areas adjacent to the stroke region. So we're not talking about an acute therapy. Obviously, we have to give patients time to recover spontaneously, so we're looking at a point in time when spontaneous recovery is done, and they're essentially left with the deficits that they have. Along those lines, we're not trying to affect the stroke core at that point in time. What's done is done, and we're actually just working with what's left. And so this is also not a prosthesis or even a substitution. Rather, as I said, we're working through endogenous pathways to establish an environment that we think might be more conducive to functional reorganization. So our experience in the preclinical ischemia model, essentially a lot of work in rodents. We started out implanting deep brain stimulation electrodes, the rodent equivalent, in the lateral cerebellar nucleus, which is the rodent homologue of the dentate. And much of this work, Jessica was very early, as soon as we actually had money to pay for somebody, was one of the first people in our lab, and she's now moved on to become a medical student at the CCLCM. And the reins have been taken up by Hugh Chan, as well as Nicole Matthews currently. But much of this work has Jessica's fingerprints all over it for the last 10 years. And one of the things we first wanted to demonstrate was whether we could translate those single pulse findings. So we know if you do very low frequency single pulse, you can cause M1 neurons to fire. But we needed to know, could we sustain that activity? So using intracortical microstimulation techniques in a rodent combined with essentially to induce MEPs and record EMG, we looked at the effects of intracortical microstimulation off and on stimulation, and that would be stimulation in the lateral cerebellar nucleus. And it's shown here in sort of a sawtooth pattern where we would do baseline off on the far left, so that's a root mean squared ratio of the post-op or the post-stimulation motor evoked potential to the baseline. So root mean squared ratio, this is a 100-minute experiment. We start off with the stimulation off for 10 minutes, just periodically doing intracortical stimulation to generate an MEP. We turn on stimulation, shown here, as the tooth goes up at 20 hertz. We see that our index of excitability tells us that the cortex is more excitable. We're getting a larger muscle response to the same level of cortical stimulation. We turn it off, we come back down to baseline, back on, et cetera, et cetera. So we did that at a number of different frequencies to look at the tuning curve of the response, and found that the effect of our stimulation in the LCN is indeed frequency specific. So this is the combination of those 10 minutes of baseline activity averaged over a series of animals. And each color here represents a frequency at which we were stimulating the lateral cerebellar nucleus during the experiment. Green is 20 hertz. It gave us a little bit of a bump in excitability. The red and the blue, assuming I get that order right, are 30 and 40 hertz. And like 20 hertz, we get a sustained effect but a little higher than 20 hertz. We move to 50 hertz stimulation, we get an acute response, however that degenerates over several minutes. And at 100 hertz of stimulation in the LCN, it doesn't show up in the average, but usually the first 2 or 3 pulses would show increased excitability, but the effect would quickly dampen and actually even trend towards reduced amplitude over time. So this helped us map out what frequency we thought might actually be used chronically to sustain a cortical excitability change. Obviously, behavior is a big part of this. So we've done a couple of different models of stroke in rats, a 3-vessel occlusion model. What's shown here is an endothelin model, endothelin 1 model. The slice over here shows a lesion induced by injection of endothelin 1, which is a potent vasoconstrictor with a timeline of about 9 hours or so before resolving. So it provides a very nice lesion. And we can measure the size of that lesion. And before we do give the animals a lesion, we train them on a pasta reaching task, see how many pieces of pasta they can reach out of their cage and break off as an index of motor behavior. And we compare them at their pre-stroke baseline, post-stroke baseline, and then here we differentiate between the STIM- and STIM+ groups. And we see a significant effect of stimulation on motor recovery in the animals. To extend that work, and try to better understand what it is that we're having an effect on, we again went back to intracortical microstimulation in a grid-like pattern to map out functional representation of the cortex before and after stroke. So the naive animal here, we see a lot of representation for lowest threshold stimulation evoking distal and proximal limb activation. And after stroke in the sham-treated animals, that distal and proximal limb activation is largely gone. After therapy, these are surgical shams. They received an electrode, but they did not get stimulated. Animals who did receive stimulation tended to show an increase in the proportion of representation for distal and proximal limbs. Even further beyond that, largely with the help of Hugh Chan, we also looked at what is underlying this in terms of cellular and molecular changes with some 3D electron microscopy showing samples that were taken in the perilesional region, sample 1, 2, and 3 shown here, sample 1, 2, and 3 shown again here in the blocks, and just counted the number of synapses within each of those blocks and found that treated animals relative to untreated animals showed an increase in the average number of synapses per sample. This was further corroborated by Western blot techniques and other immunohistochemistry showing that there is an increase in markers that typically go along with long-term potentiation and the levels of synaptophysin. And that was a summary of some of the key points over 12 years worth of work that led us to human translation, which started about 2 years ago and is called the Eden trial. So here we're essentially talking about dentate nucleus, deep brain stimulation to enhance chronic post-stroke rehabilitation. It's a phase 1 safety and feasibility trial. Like I said, it's about 2 years old at this point. Our goal is to get 12 patients, obviously adult range patients with a unilateral stroke in the territory of the middle cerebral artery. And like I said, we're talking about chronic patients. So the patients are 12 to 36 months post-stroke. At this point, the typical candidate will have a persistent moderate to severe residual unilateral upper extremity hemiparesis with a Fugl-Meyer score of less than or equal to 33. Fugl-Meyer is a scale that ranges from 66 for the upper extremity to be normal. So 33 is about 50% of reduction from that. Just to point out, the reason the asterisk is there is to remind me to say that that's a recent change. In the original 6 patients that we recruited, the FDA limited us to actually much more severe patients with a Fugl-Meyer on the order of 20 or less. So the data I'll be showing you represent those patients, and we're in the process of still recruiting now with this more flexible criteria. One of the other key aspects of inclusion criteria for this, obviously there's quite a number, but we did want to make sure that the pathways were still reasonably intact. So Ela Plow's group would help us out with that by using TMS to demonstrate that we could still reliably elicit some type of motor evoked potential in the upper extremity to criterion levels. So it's a phase 1 trial. It obviously has a lot of metrics. Since it's phase 1, safety and feasibility is supposed to be the key there. And behavior makes up the other part that we're obviously very interested in, with the Fugl-Meyer upper extremity being our primary metric and a number of additional secondary metrics. In addition to that, obviously medical history, a good deal of imaging that I'll talk about a little bit more about, and electrophysiology that I'll also talk a little bit more about. As far as the feasibility of this, it is a rather unique entry in the world of deep brain stimulation. Parkinson's and essential tremor and dystonia and those approved indications are going to have more of a approach that involves the top of the head. Here we're actually entering through the posterior fossa with a suboccipital approach. So most of the equipment is relatively standard. This is a Lexel frame, the typical microdrive that would be used to advance and retract microelectrodes, or the DBS electrode. But in this case, the patient is belly down, and partly because of that, the patient is under general anesthesia. So intraoperative physiology is a little problematic, but we do have O-arm guidance to help us ensure that the electrode is headed towards the right spot. Post-implant, I'm going to just stop that. To give an idea of where things are going. Sorry, that's getting out of control. The IPG is implanted in the chest, just like with regular DBS systems. The extension wire is this part coming up here from the left-hand side to a connector placed above the neck. And this is all excess wire, because the DBS leads are essentially one size fits all, that it remains outside of the skull. And if we look here, we can see the whole burr hole in the posterior fossa and the tip of the lead entering the skull. Again, unlike typical DBS targets, this one is only about 4 centimeters deep, so it's not that's why there's a lot of excess lead. And you can see the burr hole craniotomy here. The hyperintense signal is just the wires until it gets really bright, and that represents the contacts of the DBS lead in the dentate nucleus, which is the dark structure you see bilaterally. So, skipping ahead to outcomes, we are midway through a study, so there aren't that many. We have 6 patients implanted at this point over the last 2 years. 2 of those have fully completed the trial, so essentially they've gone through the, it's approximately 20 to 24 months depending on progress. 3 patients are still in DBS plus rehab. 1 is still in programming phase, and there have been no serious adverse events. I think I forgot to discuss the design of the trial really briefly, if I can just go back. It's a wedding cake design. We do a baseline before we do anything with the patients of about 2 months, where we send them to rehab, because we want to make sure that they're not just going to get better with rehab. Because there's a criteria that if they get so much better just by coming to the rehab that we're going to do throughout the study, then they can't be a candidate. We have to consider that maybe they just didn't have sufficient rehab to begin with. Time 0 marks at the time of the implant. Patients are allowed a 1-month recovery without any intervention, and then they come back for essentially what is considered the baseline rehab. It's 2 months of twice-weekly rehabilitation here, I think at the Walker Center, under the guidance of Jay Albert's group, where they are scored on the Fugl-Meyer once per month. At the end of that 2-month period, we do some programming, try to optimize, figure out how we're going to stimulate the target area for a given patient while rehab still continues. And ideally, beginning the 4th month, they enter the testing phase. The testing phase involves stimulation at a given setting, plus continued rehabilitation. After 4 months, although it's extended now for reasons I'll show you in a moment, stimulation is stopped. They continue rehabilitation, and assuming they don't show too much or any detriment, because again, we are talking about trying to promote plasticity. We don't consider stimulation to be an essential, necessary, like it is in Parkinson's disease or essential tremor, where you need ongoing stimulation in order to maintain benefits. The patient will be explanted, the device will be taken out, and go into long-term follow-up. Sorry about that. So this represents the data from the patients we have to date. Eden's 1, 2, 3, 4, 5, and 7. They're a little bit out of order. Eden, this is the rehab phase before they were implanted, should stay fairly flat. Rehab only should stay reasonably flat. Start stimulation about right here. We're hoping for the curve to obviously go up for the sake of these patients. Eden 1 did remarkably well. That's a 20, I'll show it in a minute. By the end of the 4 months, had a 20-point improvement. Others didn't do quite as well, and I'll show it a little more clearly in a moment. Eden 1 is why we ended up extending the trial from 4 to 8 months, or up to 8 months, for testing, because we went to 1 month, 2 month, 3 month, 4 month, and it was hard to justify just turning her off at this point if she was still making gains. So we went back, adjusted the protocol to allow us to do it based upon a 3-point moving average. So a little more close up of that, just normalized to the last the last assessment prior to stimulation being turned on. Obviously, Eden 1 sets a very high bar for recovery, and the subsequent patients have lingered with more modest effects. 3.5 is often considered to be a clinically meaningful effect of therapy. It was what was used in the North Star trial and other trials related to it, but still obviously fairly modest compared to the first patient. So one of the issues with this type of work, and again in contrast to Parkinson's disease and essential tremor where there is some heterogeneity, is these are the first 5 patients that were implanted, and these patients all had a middle cerebral artery stroke. So, but they're not very similar as far as the location of the final lesion across patients. Obviously, this is just a one-cut slide for each, but we can see there's a remarkable amount of difference in just the residual area, the residual brain, as well as the amount of current or the amount of amplitude necessary for TMS to evoke movement in each of these patients. So we do have some heterogeneity to deal with. And that type of variability, both in terms of the outcome and the patients, is okay as long as we're trying to learn something from it. So for every patient's sake, we hope they get better, but if they don't get better, we're hoping to figure out why. So my next series of slides is some of the things that we're doing to try to better understand why. And a lot of that really revolves around what can we do to better pick patients if we move forward with this type of work. What tells us whether or not our targeting is optimal, and also how do we program these patients. And some of the things we're including in those things are for patient selection, we go to imaging. We obviously do anatomical imaging, but one of the things we're really interested in is the level of striatal and thalamic involvement for this type of therapy. Both the anatomical and functional imaging, whether it's PET, resting state, or DWI, we're hoping will tell us a little bit more about the individual integrity of the dentato-thalamocortical pathway, which is obviously important to a therapy that is trying to modulate activity across those fibers. We may also be able to do that with some electrophysiology using the concept of cerebellar brain inhibition and TMS. When targeting, we're trying to further identify biomarkers that tell us if we're in the right spot. Like I said, the anesthesia is a confound for that. And then I'll mention an externalization phase where we actually have access to the DBS lead, the 8 contacts of the DBS lead for several days post-implant and post-explant, well, pre-explant, to do spontaneous and task-related recordings, as well as advanced stimulation paradigms, by which I mean things that we can't do with an implanted stimulator. And I'll talk about a couple things that we're doing which extend the rodent work to look at acute excitability changes, essentially the human equivalent of doing the intracortical microstimulation in rats, and some other electroencephalography and DBS evoked potentials. So built into, and with the thanks of the funding from the Brain Initiative, we were able to extend some of our imaging work. We get baseline PET data for the sake of looking at cross-cerebellar diaschisis. In these patients, oftentimes, even though the primary infarct is in the cerebral cortex, the loss of function of that area of the brain means a lot of things downstream or that are involved in those loops tend to also reduce their metabolism, and the cerebellum is no different. So even though in these patients you may see the infarct out on the cortex, you can see reduced activity in the contralateral cerebellum. So we're looking at those types of changes. How does our therapy affect the metabolism? Fundamental baseline issue of comparing off versus on PET imaging to see how we're impacting metabolism across the brain. And then back to MRI with functional MRI done pre-implant and post-explant to look at functional connectivity across the brain as a potential indicator both of what effect we're having on the brain and, like I said, perhaps in the beginning, something that can tell us about patient selection. Electrophysiology within this design, like I said, we externalize the patients, which I'll show on the timeline in a moment, but we can get scalp EEG combined with electrophysiology from the 8 contacts that are implanted in the dentate. We can do that in the operating room, but under anesthesia. And then we have 2 7-day periods in which we have that temporary external extension available to us. One right after implant, between implantation of the lead and placement of the battery, and then again at explant, when they take the battery out, but before they take the lead out. We also use EEG as part of programming for reasons I'll talk about in a moment, but at that point in time, it's all connected to the IPG, so we no longer have access to the electrophysiology in the dentate. And this is sort of an overview. Raghavan Gopalakrishnan and Darlene Floden are involved in the motor and cognitive task-related recordings. The dentate is a structure that we tend to think more along the lines of motor, but it does have non-motor function, and Darlene is exploring those in these patients. And Raghavan is exploring more along the lines of the data related to the task that I'll show you in a moment. We also do deep brain stimulation evoked potentials, which I'll explain in a moment also, that is more or less along the lines of any evoked potential, but the time lock signal is the actual stimulation being delivered to the brain. We do SSEPs, and with the help of Ela Plow and her group, like I said, we do TMS to look at acute changes in cortical excitability in response to stimulation, as well as serial mapping to look at functional reorganization over time. So we have the patients do two tasks that actually David helped us set up with the hand dynamometer. This is showing a simple reaction time task. We also do a block tracking task. The patient, in the time scale, basically it's 0 is the onset of movement, there's a go cue, so a reaction time, they're asked to squeeze until the ball goes into a target field, relax as soon as possible. They have a little bit of trouble relaxing, so these are patients that have some proximal limb movement, although usually limited in range. They either can't or mildly can move the wrist and fingers with flexion better than extension and often spasticity. So we have a fast relaxation time and a slow relaxation time. And behavioral metrics that we look at are going to be changes in reach, reaction time, reach time, relaxation time, as a function of the DBS setting. So now we're in the programming phase, trying to figure out, I have 8 contacts on that DBS lead. It's laid across the dentate nucleus. Which is the sweet spot? Which is the area I want to be in? What frequency, what amplitude of stimulation do I need to be delivering in order to achieve my effect? Again, unlike Parkinson's and essential tremor, when we program these patients, they don't just get better. Right? If you're programming an essential tremor patient who's holding their hands up, you can change the setting, and at some point they become rock solid. You have an immediate visual feedback. It's probably a good setting. Go out and see how that goes and come back if it changes. More and more in the DBS world, like the epilepsies, the psychiatric conditions, and here in stroke, we don't have any immediate feedback from the patient that says, yep, over the next 4 months, this setting is going to make me get better. So we look for acute changes in behavior, the amount of force that they tend to be generating during the trial. We can look very specifically comparing DBS setting 1 here and DBS setting 2 in the off versus on condition, ask them to maximally contract with that limb and see if the setting either enhances their force generation or diminishes their force generation. Again, some type of feedback of, are we having an acute effect on the system? All of the EEG, both with the LFPs and the scalp EEG, Raghavan is looking at stimulation-induced changes in task-related beta desynchronization, mu synchronization, post-movement beta rebound, and those type of phenomenon. In the DBS evoked world, like I said, the time lock signal here from stimulation is going to be paired stimulation through contacts. We record standard scalp EEG and look at the distribution of how the individual pulses here are modulating cortical activity across the top of the head. So the nose would be up, the right ear, the left ear, and the back of the head here. The plots I'm going to show from here on out are called butterfly plots. It basically takes all of those and puts it over top in one so that you lose a little bit of the spatial representation, but it tells you that after the stimulation artifact, we do see some physiologic modulation in the signal, and we're trying to use that to understand, look for a signal that might be a biomarker of efficacy. And we do see differences when we look at that signal. So the top image up there represents, again, it's a cartoon, but stimulation between contacts 7 and 8, delivered at 6 hertz, 100 microseconds, and I don't have the amplitude. And we see, following the stimulus artifact, a peak at about 30 milliseconds, a second peak at about 46 milliseconds. They don't really matter because, as of yet, we don't know what to make out of them. What is the important part right now is that if we shift stimulation to 2 minus 3 plus, look at the same response across the cortex, we now get an earlier peak and a much larger peak, largely in the opposite polarity, but about the same time, with different, again, just sort of very simple current source density imaging, suggesting that the area of activation, the dipole, has shifted to a different location. But just like the variability in our outcomes, the variability in our stroke morphology, these responses, and this is now just taking, see the 8 contacts of the lead, this is adjacent bipolar stimulation of 2 to 3, 3 to 4, 4 to 5. You can see, again, a distribution. That's the one we just looked at on the last slide. And there is a distribution of the activation changes. Some are a little messier. This is all just raw data, but there are certainly differences in them. We see at least one patient with no response at all. And interesting as far as whether or not this might, further evidence that this might be a reasonably sensitive metric is starting in patient 4, so 4, 5, and 6, we shifted to a directional DBS lead. So instead of having 8 annular rings linearly placed, it has one ring at the tip, 1 ring at the back end, and the middle 2 are broken into 3 contacts, about 120 degrees each. So you can, in theory, sculpt the current so that you can shift one way or the other relative to the long axis of the lead. And stimulating here in 2 negative, 5 positive, which would be these two contacts, 2 negative, 5 positive versus 3 negative, 6 positive versus 4 negative, 7 positive, just sweeping that current around gives us a different response at the level of the cortex. And finally, in the realm of trying to find ways to program and determine what settings these patients should receive, we again have help from Ela Plow's group, who uses TMS in the vein of the motor evoked potential studies we saw in the rodent, where we do a baseline measurement in the off condition, and then a measurement after about 45 minutes of stimulation at one setting, and then again an off, turn it off at 60 minutes, wait an hour, and get a MEP assessment again. And looking at the active motor threshold as a percentage of the maximum output, we get a score of 64 in this case, the setting necessary to provide the criterion MEPs. And in the baseline condition 64, we see a 15% drop in the amount of energy necessary to achieve that same criterion level, while 30 hertz dentate DBS is being delivered, which after the hour of rest reverts back to its original. Similar data just from the resting motor evoked potential state showing an increase in the rest. And to the extent that we can blind everybody, we blind everybody and do sham protocols as well, where we don't see that type of effect. So a promising metric for stimulation. So as an interim summary, obviously new interventions are needed to promote rehabilitation after stroke. The therapy that we're evaluating has been well tolerated by the 6 patients that have received it thus far. And some of the early data do corroborate our preclinical laboratory experience, and we're learning that we do need to develop better metrics to program and help optimize the therapy delivery. And we have seen some level of improvements across 3 patients, with the obvious caveat that this is a non-controlled phase 1 study. I think I'll wrap up there then. Sir.
That was great, Ken.
Thank you.
I mean, I'm really fascinated by stimulating in intact areas to sort of help rehab. It's been a long time idea of mine too that I never did anything about, so it's nice to see. I'm curious about the impact on things like hypertonia and flexion synergies, for example. You know, people develop, often with a stroke, they develop this flexion synergy. Have you done any assessments of stimulation in the cerebellum that might, mediate that a little bit, sort of lessen that?
We started tracking, spasticity in, I think after like patient 2, we added a couple of metrics to try to look more closely at that. I don't really have outcomes to be able to share with you, but we are looking at those a little more closely since you're right, it's a very relevant situation. And we have had patients reports of reduced tone as a result of stimulation. So.
Since I have the microphone, one more quick, easy one. What do you do with the implant and the leads and everything at the end of your time period? Do they stay in, or do they you explant everything?
We explant everything.
Thank you for a great talk. Have you done in the preclinical work an examination of how far anterior you can go to pick up a signal from stimulation cerebellum? You're looking at the motor area, but you can go to the other areas up to prefrontal cortex in theory, correct? Mm-hmm. Have you tried to track how far rostral you can pick up the stimulation?
So as far as the scalp EEG that we do?
Yes.
So we do about 30 channels of scalp EEG. It's a modified 1020, so we do get those anterior electrodes. And I don't have the data here to show, but and again, it's gross and has all the caveats that go along with current source density, but you can actually see that it shifts across anterior and lateral areas in some patients, depending upon how stimulation.
Right, but in the rats, if you
in the rats.
stimulate the cerebellum at different places, how far rostral can you get? Can you pick up the response? Can you get to the prefrontal cortex, for example?
You can get to the prefrontal cortex. It's not work that we've done. There have been single unit recordings done by others, can't remember the names, of cerebellar stimulation looking in those areas and having seen both the track tracing studies support those connections, as well as physiology supports those connections.
So let me push you then in proof of concept. If you can do this in the motor areas, presumably you can also then adapt it to change prefrontal and cognitive function, right?
Yes. So if you're baiting me, that's great. So we have tried this in an FPI. We have tried this in an FPI-induced model of TBI in a rat. Once, in one case, we did it over, the FPI was done over motor cortex. And Hugh Chan is lead author on that and just published that, and we had favorable outcomes. Obviously, motor is not what people tend to think of for TBI, so we switched and got a CCI, control cortical impact device, that allows us to do midline frontal damage in the rats. But we are, like I said at the beginning, we're a motor lab. So we are gearing up and learning about Barnes maze. We can't do the water maze, but other types of trying to figure out what are the best metrics to look at those animals as a function of stimulation. But yes, that is one of the goals in our mind.
And last question, any side effects that you saw that you didn't expect?
There has been only one very, very reproducible side effect. The anterior contacts. When we had the 8 contact lead, we pushed it as far forward as we could. The anterior contacts will quite reproducibly cause the room to spin and the patient to throw up. So vestibular fiber pathways coming up into the cerebellum. So it gives us a hallmark, and we just avoid those. But that original lead that we were using, the cerebellum, the dentate is about 1.6 centimeters in length on average, and the lead was approximately that. So we had a lot of room in that first electrode to play with.
So you gave us some ideas of the next steps, patient selection, the things you would look at for closed loop stimulation. I was just wondering if you could give us a little more on how you would rank those, or what you would weight most or be the most valuable when you're trying to select between all those options? Like what you might do next, or...
Well, I think our first one, as far as I'm concerned, is really along the lines of patient selection. So I showed the one slide where when I did the DBS evoke potentials, it was essentially a flat line other than the first initial sharp peak in one of the patients. That was sort of the moment I looked at that and did it again, tried something different. But 80 some odd derivations of stimulation across that, nothing. So that was probably my wake-up moment of saying, we should probably check and make sure that the pathway is still talking to the cortex. And that happens to be the largest patient with what looks to be the largest lesion. And that has pushed us back to saying, okay, we need to pay attention to the resting state data that we're collecting from these patients, use the functional connectivity data to seed the dentate versus the cortex, and make sure that it does appear that there's actual integrity of the pathway, which we can do in rodents. So that's one of the aims of the current rodent grant, is to try to parse some of that out by going in. The endothelin one provides very nice control of the injection sites to take out different areas. Sir.
So I know it's only 6 subjects so far, and you're in the middle of the study, and you don't want to make too many conclusions. I'm sure it must have been really sort of falsely gratifying to see that first subject and how much they improved, and then the other ones. Is there anything related to the later subjects? Are they a similar severity that they seem more clustered together than your first subject? I know you just changed the inclusion criteria.
Yeah, so those first 6 patients were all, the numbers were on that one slide. They were 14 to 20 on their Fugl-Meyer, so they were pretty close in severity, pretty close in function. One of the major gross differences was the manifestation of the stroke itself, how much tissue loss there was versus probably a focal pathway lesion type thing. So I don't really have a good sense of the distinction from that perspective. I think we just need to look at the data that we're actually collecting from these patients. So.
I'm going to push you a little bit on early intervention. So you made a statement that you have to wait for all the recovery after the stroke to happen and natural recovery from rehab. Is that a proven reason to wait, or is it more of a, well, let's just wait and see what happens. Maybe they won't need this at all, because you might miss the really plastic part, when the recovery is happening, and by the time you wait until they've reached a steady state, not only has their brain reorganized, but their joints are stiff and they've developed bad habits, basically because one of their limbs doesn't work very well.
Yeah. No, the issue of functional plasticity versus maladaptive plasticity, where to hit that curve, I agree. It would be nice to hit them as close to that 6-month window. It would probably be very difficult to ever justify going within that 6-month window unless you had better factors that said, you know what, at 6 months this patient's going to look like this no matter what, so we should try something now. I think right now we start out conservative and we can shift back. And there's other things that we're looking at along the lines of not necessarily the maladaptive, but other barriers that might be in place. So we are also looking at different peptides and options for trying to maybe break down some of the, I guess the easiest way is like the barriers that might be actively inhibiting plasticity. So.
So I do a lot of spinal cord injury work, and it's the same sort of thought that you have to wait for natural recovery to happen. And often it's too late to do anything when it doesn't turn out the way you'd like. I just wonder if there's a way that you could, you said, well, it'd be really hard to do this before 6 months unless you had some other evidence. How do you get that other evidence? We've tried to do this, and we've had a little bit of success in spinal cord injury, but it's tough. You're doing a pretty major intervention there.
Right.
But how would you find a way to push that barrier back? That's kind of an important question to me.
Yeah, I don't know. One of the limitations we have with the rodent model is just longevity that we've been dealing with. Right. So the natural lifespan of the animal makes some of the more chronic studies. So we are looking at, I don't think I mentioned, some other models for this stroke work that would have greater longevity that we may be able to vary our time of intervention. So that's. All right. Thank you very much.
Thank you.